Good afternoon, and thank you all for joining us for the session today titled Collecting, Measuring, and Estimating Costs of Healthcare Innovations in Alberta, the Case of Physician Payment. Today it'll be presented by Dr. Amity Quinn. Next slide, please. Before we begin, we would like to acknowledge the traditional territories of the people of the Treaty 7 region in southern Alberta, which includes the Blackfoot Confederacy, comprising the Siksika, Piikani, and Kainai First Nations, as well as the Tsuut'ina First Nation and the Stoney Nakoda, including the Chiniki, Bearspaw, and Wesley First Nations. The city of Calgary is also home to the Métis Nation of Alberta, Region 3. Next slide. I am Janine Liao, Assistant Professor in Community Health Sciences and a Research Scientist in Infection Prevention Control at Alberta Health Services. I have the pleasure of introducing Dr. Amity Quinn today. Dr. Quinn is a health services and health policy researcher. She's a postdoctoral fellow in health economics, supervised by Dr. Braden Mans, and instructor at the University of Calgary's Cummings School of Medicine. Her research focuses on the supply of health services for people with chronic diseases and what facilitates transformative health system change. Dr. Quinn's active projects address drivers of physicians' treatment decisions, methodological approaches to estimating healthcare variation, and identifying effective and feasible policies and interventions to improve the quality and value of Canadian healthcare systems. Earlier in the fall, Dr. Quinn and I co-hosted a health economics learning series in partnership with Alberta Health Services Strategic Clinical Networks, the University of Calgary's Health Economics Group, the University of Alberta, and the Institute of Health Economics. The session recordings are posted on the external AHS website if you are interested in exploring the topics that Dr. Quinn will be presenting today. Dr. Quinn's presentation is adapted from this series. As a quick reminder, you may submit questions to Dr. Quinn in the Q&A box, which will be addressed after her presentation. In the event that we are not able to answer all your questions, we will provide Dr. Quinn with the questions to answer following today's event, and responses will be provided in a follow-up communication. So with that, I'll pass it on to Dr. Quinn to begin her session. Thank you.
Thank you so much, Janine. I really appreciate the introduction and had a great time working with you and getting to know you on the learning series in the fall. So today I'm going to be doing a lot of things. I want to introduce you to the learning series itself, introduce you to cost analysis methods, introduce you to causal inference methods, and also introduce you to payment and delivery innovations, and specifically looking at some of the research that I've done in physician payment in Alberta. So the specific objectives, which really align with what the learning series was trying to do, are to introduce you to how to use and apply costing analyses, determine what cost data should be collected or utilized to assess the impact of an innovation, and what data is available in Alberta, and then review quantitative analytic methods to estimate the impact of an innovation on healthcare costs. And then along the way, we'll use some examples of physician payment reforms. So our path through today is to first talk about why and how to study healthcare costs, and then understanding cost data that we would need to study our innovation and what we have in Alberta. Then look at how to look at an example of that in some of my physician payment research in Alberta. Then talk about some stronger study designs, and then have some discussion with all of you. Okay, so jumping into why and how to study healthcare costs. As most of you probably know, as you're joining an O'Brien and Community Health Sciences Institute webinar, healthcare spending in Canada is a hot topic, especially as like COVID has increased healthcare spending growth. Healthcare spending represents about 12% of Canada's GDP in 2021, and it takes up about a mean across all provinces of about 40% of provincial budgets. So this is a really big area of spending in Canada, but despite how much we spend on it, we actually aren't getting really great performance for our spending. So a recent Commonwealth fund out of the US that compared Canada to a bunch of other similar countries, found that Canada's performance was second to last of those 11 countries. Only the US was faring worse in terms specifically of like performance to the amount of money spent. So we don't just want to necessarily like stop spending all of this money on healthcare. We might actually in some places want to spend more money to improve costs, but it's really about thinking about this relationship to what we're getting for the money that we're spending. So we really should be aiming to improve the value of care for our patients. And that includes thinking about costs. It includes thinking about quality of the care delivered. It includes thinking about patients' experiences, physicians' experiences, and other providers' experiences, and as well as the health that's produced from the system. And as we know, like health doesn't only come out of the healthcare system. There's a lot of other systems and social services that go into creating health. And so if we're thinking, we might even be thinking about all of those other kinds of areas of spending and interventions. Okay, so again, there's all different kinds of things we might want to do to try to improve healthcare delivery and that balance of quality to costs. And we might want to we might want to look at, sorry, there was that money was supposed to be spinning around to remind us. We could look at how much these innovations cost before we implement them, so they could help guide decision making on what we are going to pay for, like would a public drug plan cover a new drug? Or we might want to study the cost of the innovation after it was implemented to make sure it's doing what we thought it would do, see if it has any unintended consequences, for example. So my research is really in looking at system innovations, like changes to payment and delivery after they happen. So there's different kinds of cost analysis methods you might want to use before, like doing decision analysis or health technology assessment versus after. So I'm going to be focusing today on those things you would use to study what's going on after you implemented it. So this is one of my favorite slides from one of my old professors, Dr. Stuart Altman, when I did my PhD, and he was involved in US healthcare delivery, like in payment reforms, like since the 1970s. And my point in really showing this to you is that we want to think not just about changing how things are paid for or changing how things are delivered, but really the alignment between those two. So that's the idea of this chart, is to show on the y-axis different types of payment, ways you want to pay physicians or ways you want to pay a hospital, for example. So you go from, like, at the bottom is fee for service, so you're just paying for one procedure at a time, and then as you go up, it gets kind of more and more aggregated. The payment gets more and more aggregated, and those more and more aggregated payments probably are going to align better with more integrated, coordinated delivery systems and support that kind of work. So one takeaway from this is we see fee for service payment is more connected to that solo practice at those at that like really 0 point on this graph. And so if we want to do more team-based care, fee for service probably isn't like the best way to pay for that. And fee for service is the most dominant way physicians are paid in Canada. Okay, so when we make these kinds of payment and delivery reform changes, it's really hard to do a randomized experiment. So we know randomized experiments are like the ideal, like gold standard of how we want to see if a treatment is effective or not. But in these sort of real world healthcare system change settings, it's very challenging. So, but there are some examples of it, like you might have heard of the RAND health insurance experiment. And there are some like very creative sort of social randomized control experiments that are being done by some groups that I know about. But so if we think about the ideal randomized control trial, you have one population, you randomize them to getting an innovation or not, and then you compare the results, and you feel comfortable comparing the results partially because you know they all come from the same population. But in an observational study, we can't do that randomization, and as a result, like we can have a comparison group, but we don't know that comparison group came from the same population as the group getting the intervention. So that just introduces a bunch of potential biases of like why a group got an intervention or didn't, and we don't know if they were the same before or after getting the intervention, for example. So we just don't have as much certainty in comparing our results. So there are some strategies to improve our confidence in our results, and these are commonly referred to as causal inference methods. And so that, if we're thinking about what that like means in more clear English, we want to think about did our intervention cause the effect that we're seeing. And I know we're often very careful to say association, and that like a correlation it might be a correlation, not causation. But the idea here is to do the best we can to feel more comfortable, more confident that like the intervention that or the system change that we implemented is what led to a change in quality or costs or patient experiences, for example. So there's different places in our research process that we can do this. We could do it when we're designing our study, or we could do it when we're doing our outcome analysis. So if we're thinking about doing it at the point where we're designing our study, we would want to think about having as similar comparison groups as possible, including pre-post analysis, and then a strategy like so a lot of that is thinking about like when you're setting up your study, you might like set it up as best you can and then still realize your groups are kind of different, and there's methods, propensity score approaches that you can do to then like essentially try to create an even more similar group. And I'm going to be talking about that a little more later on in the talk. And then there's other approaches that you want to apply when you're doing your outcome analysis. So you can use, I think we're probably all pretty familiar with multivariable regression to like, control for confounders. A more sort of exciting new type of analysis is instrumental variable analysis, which I'm not going to be talking about today, but that's an interesting area if you're trying to find some cool new methods. And then I just wanted to highlight quickly that there are some challenges of doing this outcome analysis when healthcare costs are your outcome of interest. So healthcare cost data isn't sort of, has certain characteristics, like, so there are a lot of people who don't use any healthcare, so they have all these zero costs, but then there's a few people who have super high healthcare costs, so there's this skewed nature of it, and that's just one of the challenges. But so you can't just like necessarily automatically go in just using an ordinary least squares regression, and that's a talk for another day, but I just wanted to bring that up for now. Okay. So I just want to say, you don't have to just take my word for this. The Nobel Prize for Economics in 2021 was partially awarded for these for contributions for these causal inference methods by Josh Angrist and Guido Imbens. And so if you're interested in this, like, definitely go check them out. Josh Angrist is a great teacher, and he has a whole YouTube series on causal inference methods. So there's other resources out there for you to learn more about this. Okay, so moving into the next section of our talk, so understanding the costs that we need and have in Alberta. So CADIF has this costing guidance document that is very helpful if you're learning how to do costing analysis, and it was sort of our foundational reading for the learning series and really guided all of the examples that we did and the topics that we covered. And so there are 7 key steps in doing the cost analysis. And this is really separate from the idea of when you're studying this before and after. These are just kind of like, if you're doing cost analysis, these are things that you want to think about. So you want to set your decision problem, which is really like defining your research question, identify the cost resources that are relevant to your question, measure those resources, value them or assign costs to them, then identify variability, uncertainty, and bias, and then report your results. So one of the most important parts of that setting the decision problem or defining your research question in a cost analysis is deciding what perspective you're taking in the analysis. So CADIF recommends, and most research in this area uses a in Canada, a publicly funded healthcare approach, or like a healthcare systems perspective. So in that sense, we'd be thinking about Alberta Health Services or Alberta Health's perspective. Then if you're thinking about like a patient's cost or a society's costs, like you'd be moving either outside of just healthcare system costs, or thinking about if on the patient, if you're using a patient perspective, like they're not in Canada, they're not going to pay for their hospital stay, but they would be maybe paying for a copay for their medication or paying for travel time. So that would be like a direct healthcare cost, or the travel time to get to the hospital, which would be like an indirect cost. So anyway, the main point is you want to really think about whose perspective you're taking here, and then which costs are really relevant. And that's going to also, maybe the type of costs you're interested in are also going to vary by like what type of intervention you're implementing. And so if you're studying anything in the healthcare system, we're probably going to be studying some sort of healthcare encounters, of which there are many: hospitalizations, ED visits, drug fills, etc. But if you're doing something that's changing delivery or payment, or introducing, a new staff member, a new way of doing anything, there might be costs associated with doing that intervention. And maybe those are healthcare system costs to do this new policy, but there might also be new or different costs for patients or families because of this innovation. So healthcare encounters, like that data is going to be always collected in administrative health data, but these innovation specific costs are something that you're going to have to, if you're doing the innovation and want to study those costs, you're going to need to collect those specifically. So if we're focusing in just now on the healthcare encounter type costs, because those are something we can think of more sort of like standardized across different healthcare interventions, whereas the other ones would be different based on your specific innovation. So each kind of like place where you'd get healthcare typically has its own data set where data is regularly being collected. And then there's different groups that are responsible for collecting that data. So this chart here shows different types of healthcare resources, what is the data set in Alberta is used to collect that, and then who's responsible for collecting and managing that data. And then this data can get further reported to Alberta Health, and then like different agencies in Alberta get different databases. So I'm not going to specifically talk about how to request different data, but there are some links we have at the end of this presentation, and then we're going to post them on the webpage for this event. So if you're interested in how to request data from these different agencies, that you can check that out. Okay, so moving into an example of using this data in my research. So this is a study called the Association of Specialist Physician Payment Model with visit frequency, quality, and cost of care for people with chronic diseases. And I specifically looked at people with diabetes and chronic kidney disease. And so the specialists that were relevant were the specialists seeing those kinds of patients. So we looked at kidney specialists and diabetes specialists and general internal medicine physicians. So a little more background. As I mentioned earlier, like fee-for-service payment doesn't particularly support team-based care, which is a pretty important payment. Team-based care is like highly relevant for supporting people with chronic diseases. So if we're thinking about how to improve chronic disease care, fee-for-service payment might be something you might want to change. So in 2001, Alberta implemented this salary-based payment model as an option for specialist physicians. And I'm saying salary based because physicians aren't employed by Alberta Health or Alberta Health Services like we would see in the UK. But so physicians are still independent contractors, but they are receiving like an annual payment that covers their clinical time, and often these specialists are in academic medical centers. So this annual payment is covering research time and teaching time, for example. So this is an approach that might like both be attractive to improving physicians' quality of life, depending on what the physician values, but it also could support chronic disease care because you're not just being paid to see a patient for a visit. You're being paid in general to take care of these patients. So you could use your time in more flexible ways, like calling patients on the phone, for example, which isn't something that you traditionally would be able to bill for. So this was implemented again in Edmonton in 2001 and Calgary in 2004. And then I used Alberta Health Administrative data to study this. And taking the publicly funded healthcare system perspective. In the data that I have, we only had a variable that indicated payment model starting in 2012. So as we can see, 2012 is after 2001 and 2004. So I wasn't able to do, right off the bat, I knew I wouldn't be able to do a pre-post analysis. So in this analysis, we do have a comparison group, but I don't have a pre-post analysis. So that's a weakness of the design. And then, as I mentioned, I had looked at both like utilization and quality outcomes, but like if we're just thinking about cost specifically, I was looking at the mean total and categorical spending per patient in their first and second year after seeing a specialist. Okay. So as I had mentioned, like there's this administrative health data is being collected in these different data sets all the time. And then those records get submitted to Alberta Health, which then the way I accessed the data was through the interdisciplinary chronic disease collaboration data repository, which collects all this administrative health data in addition to some other like dialysis registry data and lab data and things like that. So so the next step again in this thinking about those CADIS costing analysis steps is thinking about what costs are relevant in this analysis. So for this project, we would want to think maybe not all healthcare costs are important, but the costs that are in a specialist physician, in a kidney specialist, diabetes specialist, or general internal medicine specialist control, and would be relevant for taking care of these new patients with diabetes and chronic kidney disease. So we think the visits specifically to those physicians are relevant, maybe visits to other physicians, because maybe we're thinking about this a team-based model. Medications are going to be important. Hospital and ED visits, like maybe not all of them are important, but visits for ambulatory care sensitive conditions might be something that's in a specialist control, because we would hope that they're not going to the hospital or emergency department for these conditions, that they should have been treated in an outpatient setting. Visits to clinics, and then diagnostic imaging and lab testing, that would be something that a specialist might order. So that's what we decided to collect in this study. So I have all of those costs on the left here, and then in the middle column, we see the different databases that those come from. And then on the right column, one thing that I haven't really addressed, and if you are interested in this, the first session of the learning series really gets into this. There's different, in these different databases, there's different ways that costs are collected and estimated. So, and then that has implications for sort of like how you're going to cost things out and how the accuracy of the cost estimates, for example. So in the, just one, this is in the hospitalizations or in the discharge abstract database, and that uses this case mixed grouper approach where you don't have the exact like price of that hospitalization, but you have this resource intensity weight value, which is telling you sort of how much resources were used during that hospitalization. And then we can link that with some estimates from CHI to get a cost estimate for like how much that using that amount of resources would probably cost like for that specific year. So that the reason that happens is because hospitals are paid a global budget, so we don't like have a specific, there's not, a hospital isn't submitting a bill to Alberta Health for every specific hospitalization. They're just getting paid a certain amount to deliver the care. So that's a contrast with the physician visits where they're collected in practitioner claims, where we're in that database, we actually see how much a physician is billing for and then how much they're paid for a specific, that is if they're fee for service. So if they're a salary physician, they're doing something called shadow billing, where they are still submitting a bill for what they did, a claim for what they did, but they're just not getting paid for that. So we were able to use those shadow bills to estimate the amount of spending for salary-based physicians. Okay, so after I got all of that data together for my cohort, I looked at the groups of patients seeing the fee-for-service physicians, and then the patients seeing the salary-based physicians, which on this chart is labeled AARP. And they looked really different. So I'm not gonna get into a lot of details comparing them or really explaining a lot about what these propensity scores are representing. But if we see on this left hand side, the before matching chart, we can see the red line and the dashed line are not the same. So we could see that they were pretty, our first thing that we learned from this is that the patients seeing fee-for-service physicians and seeing salary-based physicians were different. But if we wanted to understand the effect of the salary-based payment innovation on outcomes, we would like to have the groups be more comparable. So I use propensity score methods to essentially mimic the sort of randomization process. So we would have a more similar comparison group. So there's a number of different ways you can do propensity score methods. You could do matching, you can do weighting, but I use matching here. So essentially we used, before like doing that outcome analysis, we predicted the likelihood of seeing a fee-for-service physician or a salary-based physician using a lot of different physician and patient variables in our data set. And then you get each patient then gets a propensity score. And let's just say that's like patient A seeing fee-for-service physician as a 2.5 score, and a like patient Z seeing a salary-based physician has a 2.5 score, like we'd start with patient Z and go through the data set and find, oh, patient A has that same 2.5 score, and then they become a match. So anyway, that's just a brief introduction to this, but we can see that the matching, it did help us. If we look at this left-hand figure, after the matching, the lines are very similar. So we were much more confident that we had a similar group of patients seeing these different types of physicians to then compare our outcomes to. So when we did compare these similar groups, these like oranges, we found there wasn't statistical evidence of a difference in utilization or quality or cost between the physicians. A side thing that I found was that it actually looked like there was other variables, about other physician variables that we weren't observing, that were having a bigger impact on these outcomes than the payment model itself. So that's spun off a whole other area of research on understanding physician variation that I've been working on more recently. And then just to show you the cost outcomes, because that's the point of this talk, we can see here that there's both these dots here are the total costs for the salary fee-for-service physicians. I mean, and the total is actually higher, but again, it's like how much of these costs are in the specialist physician control, even despite like trying to pick those ones, like there might, there's a lot of other healthcare use going on for these patients. But we can see here in these the specific specialists that they saw for their visit, those are the same between fee-for-service and salary-based physicians. And then you can see, just get a sense of these different types of spending areas, like what that looks like for these patients. So, okay, so what, like, based on that, like, what do we know about the effect of the salary-based payment model? Like, it, at least for these few specialists, which are not the only ones who started this model, like maybe it didn't change care delivery, but like, again, we don't have a before and after. The payment model had already been in effect for a lot of years before I was able to do the study. So I think there's, and then a big question mark is like, who are the physicians that are they're choosing to be in the salary model? So there's probably some selection bias on how they're delivering care that's like not about the payment model itself. So there's stronger study designs that we could use here, or we that other projects have used to, again, like feel more confident that the payment or in delivery innovation is what specifically caused the effects that they're seeing, or more likely was what caused those effects. So I just wanted to like briefly introduce you to some of these stronger study designs. So in what we've talked about so far, I have had a comparison group, but I haven't had this before and after. And like a big importance of having a pre and post intervention is understanding both for the treatment group, but also for the comparison group, like what was going on before the intervention. And that if what is happening before and the trend that's happening before is going to like impact what you're seeing after. But if you don't know what's happening there, you're just missing a lot of the story. So you can have, again, both pre-post analysis. You could have a comparison group, and then but the strongest study designs have both a pre-post analysis and a comparison group. So I don't really think I have time to like really go into this slide, but this sort of, I highly, if you're interested in this area and then like communicating research to policymakers, this paper that I referenced here is really useful and practical in helping to understand like the strength of study designs and communicating the results to decision makers. But in general, what this chart is showing us is that these stronger designs that we can feel more confident in the results, or randomized control trials, or these what's called an interrupted time series that has a comparison group, so we can see that before and a long time before and after with that comparison group. Then there's some sort of intermediate confident study designs, and then the weaker designs, which like is the example of what I just showed you, but we could feel more confident in our findings because of doing that propensity score matching, which isn't something that's taken into account in this slide. So anyway, it's just to say there's both like how you set up your study and what groups and time you're looking at is one part of the design, and then like you can do statistical approaches like the propensity score matching to like further feel more confident in that. But anyway, okay. So here, this is an example that doesn't actually specifically use cost as an outcomes, but it was interrupted time series approach that I used to, this is sort of an ongoing like background project that maybe one day I will hopefully finish, that looked at how kidney specialists were responding to new evidence on at what kidney function we should be initiating dialysis. So there's been a lot of uncertainty around what kidney function we should be looking for to initiate dialysis. And there was, I can't, in like the past 10 years, there was a randomized control trial that came out that was recommending a lower kidney function than had been sort of typically being used. And there's some other studies that looked across Canada, like across a number of provinces, and showed that after that trial came out, it did reduce the kidney, so it was delaying, essentially the effect of it was like delaying the initiation of dialysis, which you would think would potentially save the healthcare system money, because the dialysis is a very expensive healthcare service, and if you're delaying it, we might be saving the healthcare system money, and more importantly, it's a very life-altering experience for patients, and so we might be improving their quality of life by waiting to initiate it. So a few years after the trial came out, there was some clinical guidelines that were released in Canada. So I was interested in both, was there any difference in the trial results versus the guidelines in affecting outcomes? And also, was there a different response to this clinical evidence by payment model? And you would think there might be, because as I've mentioned, like fee for service, you're only getting paid for the services you're provided, and like you're not going to get paid for spending time reading a journal article, for example. And there might be a difference in how you respond to guidelines versus a trial, because the guidelines are more sort of summarizing a bunch of evidence rather than like just one, not that it's not, a gold standard of of research, but just like evidence from one trial might not be as impactful as guidelines, for example. So when we were doing the study, we were able to identify kidney specialist payment model prior to 2012, and along the way have also realized it wasn't that this variable wasn't available in Alberta. It was just that in our data set we didn't have it. So we're able to get this payment model variable from Alberta Health, that then now is like opening the doors to doing some, maybe I can go back and like redo that study I just talked to you about, with looking before and after the implementation of the salary-based payment, for example. So this is a long setup, but the point really is like, because I could look before and after an intervention, and this was an intervention that was happening to the full population at a certain point in time, we were able to use this interrupted time series design, which is where there's a policy or practice change at a specific moment of time that's causing an interruption. You can do it with or without a comparison group. A comparison group makes it a stronger analysis. And you definitely, it makes it a stronger results than like more time you have before the intervention, because you're able to establish the trend that's happening before. And that's important because you would assume that the trend would continue without having the intervention. And then you're going to be partially what that results are comparing the difference between what you see after the intervention with what you would have expected the trend to be based on the pre-period. So this is a very quick and dirty introduction, but this is just showing you, so when you do these designs, you can see both like, did it just continue, like in figure A, there was no effect of the intervention, that the trend just continued. In figure B, there wasn't an initial effect, but then it eventually reduced costs, for example. In figure C, it didn't affect the trend, but something did just lower costs outright. And then in figure D, you see it both like a total amount changed right after, and then there was sort of a continuation of that trend. So these are different, you can ask different questions in a time series analysis about was there an effect of the intervention right away, or was there an effect over time, or was there effect on both of those things? And then just really quickly, these are the results for both. In the gray, it's like all the physicians together, and then the fee-for-service and salary physicians separately. Like the main interesting thing here that I found is that in Alberta, the kidney function the kidney function at which a dialysis was initiated was actually going down before the trial was published, which is again different than what we saw in the rest of Canada. And then we see there are some differences in salary and fee for service, but the study is really underpowered to really detect significant differences. But you might think that like the steepness of the line of the salary physicians might be meaning that they had more of a strong response to those guidelines. But again, this is an ongoing study. So and then just really briefly, I wanted to introduce you to another study design called a difference in differences analysis. So this is not a paper that I was involved in, but so another type of payment and delivery reform that that we could consider here is like having both a global payment. Like I mentioned, we have global payment for the hospitals in Alberta, but this innovation was specifically having a global payment, not only for that inpatient care, but for all of the care that a patient that was in this specific health insurance plan in Massachusetts received. So that would include their primary care, their labs, their medications, like all of that spending. And then what it did, the intervention had like the primary care provider for a patient was held responsible for managing those costs. And there was also a lot of quality improvement metrics that were measured in the study. And then the outcome that they had both like that healthcare plans claims data, and a difference with this study versus what I've talked about in Alberta is they don't have global payments to hospitals in Massachusetts. Everything is based on this kind of billing data. So they were able to capture sort of the exact spending per patient and compare that with their database to this commercial data on a bunch of different health plans in a bunch of different states. So a difference in differences design is also useful when there's a policy change at a certain point in time, but it might be in one place but not another place, unlike like a time series design that we just talked about, where it might be like in all of Alberta and there's like not a comparison group necessarily. So for a difference in difference, you like have to have a comparison group, and you have to have data on the outcome before the intervention for both groups, and for the longer the time, the better. And an important assumption is that without your intervention, the difference between the treatment and the control group would stay the same over time. So this is just briefly to try to illustrate like why it's called a difference in difference, because we have the difference in group 1 before and after, the difference in group 2 before and after. In this figure A, the difference is the same, but in the figure B, we see that the difference in group A before and after is different than the group B before and after. So you subtract the difference in group A from the difference in group B to get the treatment effect. So that's why there's a difference in difference. So we see here that the trend in Massachusetts is this dotted line, and then the solid blue line is the intervention group. And then this red dashed line is the control group. So what we would be looking for is that the Massachusetts trend and then that control group trend are pretty similar over time to feel like, okay, like we do see a change in our intervention group, but probably that trend, the Massachusetts trend and the control group trend are sort of staying, they're not the same, but they're going in the same direction through over time. And then we see this difference in the treatment group spending. So if we took the difference between, before and after in the treatment and the control group, we would get, so I'm not going to do all of the math on here, but again, you do the difference in the treatment group, the difference in the control group, and then the difference in the differences. So it's saving about $461 per person to do this intervention. Okay, so anyway, in conclusion, I know we covered a lot of ground today, but there's a lot of different studies we can do in this area. There's a lot of different data. There's a lot of different study designs, but it's always important to think like the data you use and the design you use are really going to depend on your research question, the context, and what's feasible. And with that, I'd be happy to spend a few minutes taking your questions.
Great, thank you, Dr. Quinn. Lots of interesting topics, so thank you so much for presenting that. We do have a few questions in the Q&A, and we have about 10 minutes for some of these questions. So to start, I'll ask, you touched on physician remuneration as a tool for influencing practice patterns. What do we know about the incentives for other groups of healthcare practitioners, and how do those incentives maybe influence those practice patterns?
That's a really good question. I honestly haven't studied that. I know there's a systematic review of payment for other types of practitioners, but I'm honestly not that familiar with it. At least in Canada, like a lot of other providers that are like working directly with physicians are paid salaries. Like, so nurses here are salaried, are paid, are employees of Alberta Health Services, for example. So anyway, I won't hypothesize. I would that there are systematic reviews on this, so look those up. I'm sorry, I can't tell you the answer, but I think one there's things to think about is maybe also like if they're being paid differently, like how those different payment models are going to impact the performance of the team, and like if maybe could there even be a team-based payment to get people to work together.
Great, thank you. So a couple of questions here just about methodology and suggestions. So early on, you were talking about randomized controlled trials and recognizing the hierarchy of scientific evidence, suggesting that randomized controlled trials are the gold standard. Are you suggesting, or are you recommending that RCTs be used as a gold standard for optimizing healthcare costs, or being used to look at optimizing healthcare costs, or are some of these other methods and approaches appropriate? And can you comment on that?
I mean, I think that if it's feasible to do a randomized control trial of a healthcare payment or delivery reform, then that's really cool. That we could like those are worth trying. But they're like very challenging to do. Like excuse me. So I wouldn't say like, let's use, can you hear me okay? Like, let's use that as a barrier. Like, I wouldn't say let's, not do an innovation because we can't do a randomized control trial of it. I would say these other methods are good tools to, again, feel more confident in our results. And if we can have a pre-post analysis with a comparison group and see an effect on cost reduction and quality improvement, then like I think, like maybe we would want to continue to study it as years go on to see if things are still moving in that direction. But those would be definitely, I think, strong designs to make conclusions. That's what, like, the example from that global payment reform in Massachusetts that I shared has done like studies every year since they implemented it to show that how the trends have continued to change.
And I think somewhat related to these designs, there's a question here about how many data points would you recommend in these pre-post study designs when you're assessing policy changes? So how many data points are required to be powered enough to have confidence in the claims from those types of studies?
Yeah, there are specific papers on that exact topic. I think I want to say 10 or 12 points before are recommended, but it also has to do with like how many people you have data on and where you're kind of rolling it up. So like if you have 10 months of data before an intervention versus 10 years of data before an intervention, yeah, and then how you're aggregating that. So it's not like most things in research, it's not like necessarily a clear cut answer, but there are research studies on that you can look up.
And then another question, are there any differences in costing for an innovation compared to costing for a new treatment?
That's an interesting question. I don't know. I mean, I think there's like some, yeah, I don't know. Do you know the answer to that, Janine? I mean, I think there's more like guidance on like costing for a drug, right? Like if you want to like implement a new drug treatment, that's like just like that's some big, like an example that just keeps coming to mind. So I don't know. Do you know? Do you have an idea?
Yeah, I mean, I don't know the nuances or specifics, but obviously you want to think of, like you mentioned earlier, your perspective of your costs, and you want to think about what costs are incurred within that perspective and who's incurring those costs when you're implementing a new drug or a new treatment. If it's an innovation, it's thinking about how's that innovation defined, how's it different from current practice, and what additional costs are associated with that innovation. And innovation is a term. It depends really on what that is and what's included in implementing that in the setting that you're in. So it is a difficult question to answer without understanding what that innovation is, but technically, there certainly would be different costs that you would want to consider if you're implementing a program or an innovation or some sort of intervention that is not a drug. I think there are different costs that you would want to consider in those two situations. Okay. So we have a few more questions and some really good ones, a few more minutes for time for questions, a few good ones. There is a follow-up question to one that was asked earlier related to incentives for changing healthcare practice. So, and based on your presentation earlier, as a province, how do we get to your Nirvana quadrant in the 4-quadrant model that you presented earlier in your presentation? And what might be concrete steps for us to get there?
Oh, that's so easy. Let me think. I mean, I think that, the evidence from that global payment model that I just shared, I think is something we could take into account and consider here. So that would, I think where that would really create the most disruption and change would be in how primary care is organized in Alberta. And because, there's just a lack of, there's not, so I'm not going to say that we are going to say we have to pick one primary care provider who that's all the only person that we go to. But if we did, let's say we did have our own family physician and they were responsible for the quality and managing all of the quality and the cost of the care that we receive, then that would incentivize them to maybe change their accessibility, change the way they're seeing us, engaging with patients, and also attracting patients to certain providers. I know personally, I have a family physician, but their hours are very limited. And if my 4-year-old has an emergency, well, not an emergency where I take him to the actual emergency room, but let's say he has a pink eye or chicken pox, and I can't get in to see them, and I can't even, they say that they have a after hours care, but that's also impossible to reach. Then I just go to the walk-in clinic, and then that's, there's a lack of communication about what's going on with my child. There's a lack of, anyway, so I think it could, if we did sort of maybe this isn't a super concrete step, but if we focused on maybe reforming primary care and having it be more organized and really maybe have a payment tied to a patient for primary care delivery, and also included some quality measurements, and think about both patient experience and access in that, not only the health outcomes. I think that would be a place to start.
Okay, so just for that last comment then, so would you say that addressing these issues in primary care are one of the biggest barriers that we need to overcome to address some of the healthcare cost and performance challenges that we're seeing? 1 minute.
I think yes, but I would also just add that I don't think I'm not trying to blame primary care also for this, because it's there needs to be connections across all healthcare settings. And I think things like tools like having Connect Care hopefully will help also improve that kind of communication and connections. But if there was that global payment that covered all of a patient's care, then that would sort of force, in at least in the economic incentive sense, that would incentivize providers to make those connections for patients. Because if all of patients' care was paid for by one payment, then you wouldn't want them to go have an expensive surgery that you didn't know about. So I think it's not only about putting it all in primary care, but making sure that there are connections between the healthcare, different areas of the healthcare system.
Great. Okay, well, thank you so much, Dr. Quinn. We're at 1 o'clock. Thank you everybody for attending today and posting your questions. Thank you, Dr. Quinn, for answering some quite difficult questions today, interesting questions. So for any questions that have not been addressed, we will certainly have Dr. Quinn review those questions and address them. And our O'Brien staff here will help us post responses to those questions in a future communication. So with that, I want to thank everybody again for being here today. Have a great rest of your day and a good weekend. Thank you.
Thank you. Thanks, everybody. Thanks, Janine.